Hello, good morning, good afternoon from La Paz University Hospital, Madrid. I'm Alfonso Jurado again. Here we have our second case of today. Beside me is Dr. Santiago Jiménez Valero, Alicia with us, Sofia, Chus, and we are prepared to show a coronary case that is going to be presented by Silvio Vera, our fellow. Silvio.
Okay, thank you. This is going to present the case. This is a 61 years old woman with history of hypertension, dyslipidemia, and type 2 diabetes. Just the week before an STEMI, we treat the culprit lesion. In this case, was the circumflex, and also she has a proximal LED disease. That is the staged procedure that we're going to do today. And the echo shows preserved ejection fractions and no other significant findings. And I'm going to show you the angio. There's no significant lesion in the coronary artery, so you can see the culprit lesion in the circumflex that was treated, and we're going to treat that lesion in the proximal LAD, and I'm going to show you here. And as you can see, we have a severe calcification, and that is we're going to use plaque modification technique. Our society has a position paper regarding the plaque modification technique to treat calcified coronary lesion that is led by Alfonso Jurado. And according to this algorithm, we have to use plaque modification techniques, but which one? In our case, our institution is doing the roller coaster trial. That is a study to decide which technique we're going to use. In this case, our patient was randomized to the lithotripsy treatment. So this is the plan. We're going to use plaque modification techniques, in this case, lithotripsy, and of course, we're going to do imaging-guided PCI. And going back to Alfonso to explain the case.
Dani, OCT. So thank you, Silvio. We are going to show you the OCT of the previous day. That's going to be shown by Silvio again. And as you can see, it's a very big vessel. Probably the reference diameter is 3.9, more or less, the luminal diameter. And this is a calcified, a severely calcified lesion, as Silvio said. So our plan is to prepare the lesion with lithotripsy. We was in the debate before, Santiago and me, if we can go directly with the shockwave balloon or it's better to predilate. A little bit, probably we are going to predilate because I struggle a little bit to cross the wire. Déjanos, Sofía, un balón de 3, a lo mejor 3.12 o así. So we're going to predilate slightly with a 3.0 balloon. $3.10. You can see the lesion in the screen. It's a thick lesion, all the circumference, 330 degrees here, probably is the wire, so the whole circumference. And that's all. Let's predilate a little bit. I don't know if the shockwave balloon, a 4 shockwave balloon that is selected by us 1:1 to the reference diameter could cross this lesion. Probably it does, but we prefer to be cautious and predilate. Okay, while we are predilating the lesion, Alicia is preparing the shockwave balloon that, as you know, needs to be prepared perfect without any air inside the balloon, because if there is any air, the sonic waves are not going to do their job. And also, if you have a rupture of the balloon, the complication could be worse. But we will go for this after that. We are trying to advance the 3.0 balloon. I think is there. Test, please. A bit farther. Okay. Let's dilate. Okay. You can see this loop bone effect at 18 atmospheres. Okay, it's enough. Yeah. Se ha roto.
Sí.
The balloon has been broken. Okay. So they expected. We are not going to inject, just a little bit to control that there is no complication, but the blood pressure is okay. Let's see. The ECG has changed a little bit. Give me a test, please. Okay. We have a slow flow.
Un poquito de nitro.
No vamos a inyectar más, ¿eh? Tiene disección.
Un poquito de nitro si quieres, pero bueno.
Vale. Venga, vamos con el shockwave, sí. Después de todo haremos OCT, pero ahora no.
Ahora después, no te preocupes, que ahora nos corre más prisa otra cosa.
Venga, vamos con el shockwave.
Vale.
Nos tendríais que dar, Sofía, el botón amarillo ahora cuando... Ok, tengo la guía. Vale. Venga, pilla las dos cosas juntas, que no sé. A ver, vale. I'm advancing the shockwave balloon. As you can see, after the pre-dilatation, the balloon was broken and the ECG changed a little bit. The patient is okay. But we're not going to inject anything more because of the dissection. Just a little bit to know I am in the position, but I am there. I think we can... yeah, button.
Te doy un pequeño
A little bit,
testito.
sí. Ok, voy a avanzar un poco, ¿vale? Por.
Un fly a 4.
Vale.
4.
You can see the shock beats there. Okay.
6.
We have to go up to 6 atmospheres and wait to this signal to get down. Okay, I think we have to do another run up to 4. We check the position. Okay, we are there. It's recommended to perform at least 20 pulses in each lesion. I think the expansion of the balloon is quite good. 6. It's another thing, different than before. What do you think?
Haría otra.
Vale.
One more.
We are doing one more. Let's give the patient a little bit. Okay. One more. 4. Okay. We're going to check their extra beats. Otro tercio de frente, por favor.
Un Sten, un
6.
Megatron 420.
420 está ahí abajo, ¿vale?
¿Nos lo echas?
Aguanta un momento. We're going to check in another projection. Okay, go down. Yeah, this is this calcification below the balloon, but I think the expansion is quite good. Okay.
Sí.
Sí. So another thing for this patient. Pequeño test, por favor, que no hay nada raro. Okay, the flow is recovered. There's no perforation. So another thing is that the patient is allergic to cobalt. So in the previous procedure, we implanted a Megatron stent, synergy stent, and we are going to do the same because, as you know, the composition of this stent has no cobalt, cobalt, platinum, and the Megatron stent is the evolution of the synergy for big vessels with higher strength, radial strength. And as we are treating a 4 millimeters vessel, we are going to implant this stent. As you can see, the ECG is again normal. The blood pressure is fine. And just to avoid any more injections, tengo la guía suelta.
¿Tienes? Sí, pero está un poquito
Retira un poco,
avanzada.
sí, retira un poco. We're going to implant the stent and then check if everything is okay. We have measured before in the OCT that the length is near 16 to land in the more healthy area. Test, please. So there is a dissection. Yeah. Se mueve un montón. There is a lot of movement. Test, please. Es un poquito más fuerte. ¿Qué te parece?
Bien,
Bien,
así
bien.
coge la disección
Vale.
hasta la parte proximal.
We're going to seal the dissection. Vamos a nominar que es como 11, ¿no?
Sí.
11, ¿vale? Okay. Going to check in another projection. Okay. It's a slight under expansion in the more calcified part, but I think the area is going to be okay. And probably we have sealed the dissection. Let's retrieve the balloon. Okay. Un poco de nitro, por favor.
Pues un test.
Creo que está
Creo
todo,
que
pero
sí está
dale,
todo
por si
bien
acaso.
para antes de que saques el balón.
Sí. It's a common practice here. This is quite useful, in my opinion, is to do a small injection of contrast before retrieving the balloon, just in case you have a perforation. You have the balloon there to do an inflation and then think. So I think everything is okay. The ECG normal. We're going to put some nitroglycerin and check.
Ahora sí vamos a hacer la OCT, ¿vale?
Sí. ¿Tres de nitro?
Sí.
Vale. In the angio looks fine. We can do a cine. Careful with the wire. Okay. Sin nombre. Cine. Let's see the distal part. Obviously, there is a
XXXX y...
slight under expansion in the proximal mid part of the stent. That is the side of the more calcified plaque. Let's see in the cranial view the distal end of the stent. I think it's nice. So we are going to perform the OCT study. I don't know if there is any question from the audience. Danny? In this case, of course, the patient has been included in the roller coaster trial that is randomizing shockwave versus rota versus laser in these calcified lesions.
Sí, lo deja.
But probably one question could be if we have had chosen the same strategy if the patient hasn't been included in the trial. And probably in this case, it is the best option because it's not a critical stenosis, and probably shockwave balloon can cross. In this case, we have predilated a little bit.
Lesion.
Yeah, and it's proximal. It's a big vessel. It's short, so probably it's circumferential. So probably shockwave for this case.
For this case, is the best option.
Is the best option in our opinion. So we are ready to
continuar. 54, sí.
Sí, la corta, ¿no? Píllame aquí, por favor, la guía, Santi. Sí, espera, tengo que subirla.
Pone 16.4.
And also, regarding the calcification, you have seen the circumferential calcification, but also this a thick plaque, and probably, be careful with the wire, probably, la tengo ahora ya. Rota is not going to do anything in this deep calcium. And laser could work there, but it's a controversial point. As you know, that classically laser has been said to do nothing to modify calcium. It is true, but only in pure calcium. But as you know, in the coronary arteries, there is no pure calcium. It's always mixed with fibrous tissue and all the...
Purgamos.
Yeah. So we are ready for do the OCT pullback.
Vale, ¿le das a comenzar?
Aviso cuando... Espera que no tengo cine. Sí. ¿Tenemos 16.4? Sí.
Sí. Ok,
¿Cine?
cine.
¿Ha visto bien? ¿No?
Sí.
Going to retrieve the OCT catheter and then we can analyze it. Si nos dais el joystick, bueno, no tenemos joystick aquí. Ayúdame aquí, por favor. A quitar esto. Ya de la... Y esto. So Santiago Jiménez Valero is analyzing the OCT. He's our expert in coronary imaging. I will see in the rapid pullback. Probably there's some malposition at some point, but the areas are quite good.
So we can hear.
This is the Ultron software.
The distal border is good. There's no dissection with expansion at this point.
A little bit malapose there, but
this is small, only two struts and
it's a small malposition there.
Little length. There is some asymmetrical expansion due to calcium in the...
I don't know if you are hearing Dr. Jiménez Valero, so I am going to repeat the things he's saying. You can see here the software. And during the measurements, probably in this mid-proximal part of the stent is the minimal stent area. ¿Cuánto sería, Santi, hacia...?
O sea que el área mínima del stent es aquí.
It's near 7.5, the MSA. Okay. Let's check again everything.
There is some slight under expansion with very near struts, but the minimal luminaria is good. The software indicates a 74% expansion. That is quite near 80%. We can use again,
Santi, que no sé si te oyen. ¿Oís a Santi? Okay, continue.
One option could be use again the lithotripsy, but we have some doubts about the effect on the polymer, etc. And the result is that with some slight mild under expansion in the midpoint of the stent, but the minimal luminaria is quite good.
Yeah, the thing is that what is the perfect or the optimal expansion, percentage of expansion? That is the primary objective for the study. In the studies, we are dividing always this thing, 80, 90%, but in the studies, in the Illumian trial, the majority of patients have memorized this 80%. So the area is quite good. It's 7.5. I don't know, to be honest, if we can improve it with more, not now, but also at the beginning with more shockwave pulses. So probably this is the best option. The other option is to, as Santiago said, to perform again more pulses inside the acutely implanted stent. We know that there is a controversial point about this for damaging regarding damaging the polymer, but we have data of the group of my friend José Manuel Montero that after 2 years of follow-up, this acutely IVL in acute implanted stent has no adverse clinical events. So we should decide with this area. Probably, I think it's enough.
It's enough. The other option is to post-dilate with a
4.0
or 4.
We can post-dilate, yeah. We are going to post-dilate with 4.0.
OCT if it is reasonable result.
Ok, nos dais un 4.0 de NC, 12 o así. So we are going to post-dilate. As you know, in the disrupt trials, the percentage of pre and post-dilatation is quite high. And we can post-dilate with a 4O balloon.
We should not be aggressive with post-dilatation because of the dissection and the rupture of the balloon. There is some damage in the vessel wall.
The common sentence, no? The best is the enemy of the good, and the area now is over the thresholds of optimal implantation. No? But it's true that this part is a little bit underexpanded, so we are going to post-dilate at nominal pressures with a 4O balloon, and we can repeat the OCT on this side. Our setup that we didn't explain before, because we have just started before the connection, is a radial 6 French approach. As you know, you can do lithotripsy through a 6 French guiding catheter, and it's quite easy. The technique is quite easy. That is their main advantage against the other plaque modification techniques, that the learning curve is slower. So I think I'm there. I'm going to do a cine without contrast.
So inside, you are a little proximal to.
We're going to posit all the stent, okay. Right?
But
no, I was
not at the distal point, no?
Probably this part, no?
This part.
Don't give me contrast, please. You can see the calcium there, so I think this is the point. Let's go for nominal pressures.
Nominal is 12.
12. 14 probably. Okay. Okay, let's do another one proximal. I think I'm there.
Yes. 14.
Okay. Usually you need 2 orthogonal projections to see the expansion, but we are going to do OCT again, so let's see a test, please, before retrieving the balloon. Test, porfa. Vale, tenemos ahí 16. Cuidado. Let's repeat the OCT. Cuidado, cuidado. So as you know, in these calcified lesions, it's difficult to have answers to which is the best option. In every meeting we have, the common sentence is we don't have randomized data, and we are having those data after this trial, the roller coaster trial. But probably the best option is always to select the strategy, looking the lesion, the patient, the time of the day is not the same to treat this lesion now than doing in a STEMI at 3 a.m. Of course, it's more important the expertise of the team, the devices you have. Okay, stay.
Okay. Vamos a hacerlo en esta proyección, que la otra nos dio un error.
Vale, espera que me toca detener un poco, que no sé, estoy fuera.
No estás bien, ¿eh?
Espera, es que me pega tirones. Cuidado, es que está muy tirante esto.
¿La mejor?
A ver. Ay.
Está bien metido.
Sí.
¿Nos dais otra pullback?
New pullback of the OCT.
Arriba a la derecha. No. Arriba y a la derecha. Iniciar retirada nueva. Ponle si quieres post.
No.
Vale, dale a continuar.
Es igual, continuar. Comenzar.
Un segundo que estoy purgando. Vale, cuando queráis comenzar. ¿Tiene? I think it's better.
Let's check it, but our initial impression is that it's better. You can see in the angio these 2 small protrusions, probably is there calcified nodules or the beginning of calcified nodules there. But the result is quite good. We also strongly believe in the combination of plaque modification techniques. In this case, we suspected that we were going to be able to cross with a shock wave, with a slight periodization.
The small luminal area have improved, and you can see here the dissection that is sealed by the stent. And in the proximal ostium, there is no residual dissection in the proximal border. And the minimal lumen area.
It's more difficult to measure areas with this new software, but they're improving
now
it.
The machine say that the minimal lumen area is 8.2.
We have improved it a little bit, no? 0.6, 0.7 millimeters square. I think it's okay. We don't have. ¿Tenemos alguna pregunta? We don't have any questions from the audience. Santiago is checking everything.
Yeah, the measurements are correct, and the minimal lumen area is 8.2.
Yeah, we always check the measurements that the software does, because not always are perfect, but now they are. And I think we are done. We can do another projection just to check distal part. It's okay. I was saying that we suspected a shockwave was going to cross, but we strongly believe in the combination of techniques. And if we have a struggle to cross with balloons, probably it's quite useful to use rota, laser, or whatever to make the channel, and then finish with the shockwave. Cine, ¿vale? ¿Vale? Cine. I think it's perfect. What do you think, Santi?
It's very good. The minimal lumen is 8 millimeters square, and the minimal expansion is 76, I think. This is the critical.
Near 80%. Near 80%.
I think it's quite enough.
Okay, just to recap before leaving you, it is not a very complex case, to be honest, but it was interesting to show the treatment of a severely calcified lesion and a proximal LAD. It's important that this technique with IVL is quite easy, is safe. You can do it by through a 6 French guiding catheter, always imaging guided, in this case with OCT. The patient has cobalt allergy, so we use a Megatron stent that also gives us this increased radial strength, visibility, and this is especially designed for these proximal big vessels. So I think we are done. So thanks to Alicia, Santi, and all the team, and we can switch off the connection. See you the next week.
Thank you.